Hello, students. Welcome back to the second part of this week's topic, which is blood product and transfusions. This is really important topic, so that's why we have separated it. And when you learn this, learn it very carefully. Okay. The learning objectives are the same. I have put a list of blood products which you will see, which is whole blood. We don't really see replacement of whole blood nowadays that much because it adds really volume to the transfusions. So what we see is packed blood, red blood cells or PRBCs. So more RBCs with little volume of plasma. The hematocrit in this case will be high. That's the highly concentrated solution. Then platelets, there are different type of platelet products available, some from a single donor. It takes about 6 to 8 unit of platelets or RB blood to make that platelet product. So it takes a lot of blood product to make the platelet transfusion. Plasma, granulocytes, cryoprecipitate in case of fibrinogen deficiency or clotting factor deficiency, albumin, intravenous immunoglobulin. Now you would see subcutaneous immunoglobulins too, which is not in your textbook, but this is a very newer product. Instead of giving as intravenous immunoglobulin, we can give it as subcutaneous infusions where patients can do it at their own homes. That is a newer product. Anyways, let's look at some of the products which we're going to learn. So cryoprecipitate, when do we give this? You usually give when the fibrinogen level is low or factor 8, von Willebrand factor or factor 13 is missing. Okay, these are the times when we usually give the cryoprecipitate. And indications are DIC with low fibrinogen, hemophilia, von Willebrand disease, especially hemophilia A, massive bleeding with hypofibrinogenemia. So whenever the fibrinogen level is low and there is excessive bleeding, the product we usually use is cryoprecipitate. The benefit of it is very small volume and it gives the clotting factors. And it's very rapid infusion and rapid effect. All the blood products, including albumin and IVIG, we watch for transfusion reaction. So transfusion pre-procedure, our responsibilities are to verify that the patient has a written consent. Now, in your practice, you will see that ideally the consent should be obtained by the physician, and we always, or the most responsible provider. Whoever is ordering the blood product is entitled to get that consent. Now, sometimes they don't. Our job as nurses is to make sure and verify that the client has given consent or they have a signed consent. It is one of the requirements for blood transfusion. Our role is to explain the procedure and double check that they understood the signs and symptoms of transfusion reaction or they understood the treatment. Before starting the transfusion, you always wanted to check their vital signs, temperature, pulse, respiration, blood pressure, and auscultate their breath sounds to establish a baseline comparison during transfusion. Orbcon usually says use 22 gauge needle. Infusion Nursing Society says you can use anywhere from 18 to 24 gauge. Because pediatric patients, we always use 24 gauge needle to transfuse blood. Well, pediatric blood is not smaller than adult blood. It's the same blood cells we are infusing. So 24 to 18 gauge needles can be used. But for massive transfusion, we probably would use 18 or number 20 when a patient is crashing. But we can use any size needle as per the Infusion Nursing Society and the Canadian Vascular Access Association. So if you look at their guidelines, it would say guidelines would say that any size can be used. Mostly in the OrbCon website, you would see 22 or larger is recommended. Usually larger when the patient is crashing. So we obtain the blood from the blood bank. You do not let it stay outside for more than 20 minutes. If you're not ready to transfuse, don't get your blood from the blood bank. You should be ready when the blood arrives. You already have made sure that their vital signs are stable. They are not having temperature, they don't have fever, or everything is stable, and have an established IV line before asking for the blood product. Then we double check. We do the independent double check with another nurse or physician to make sure that it is compatible. It says in a blood transfusion is initiated within 30 minutes. Do not delay that time. Don't wait for the 30 minutes. Infuses as soon as it's available to you. Then for the first 15 minutes, we will be running it at a rate of 5 ml per minute. It is recommended to check vital signs every 5 minutes, but I would usually recommend nurses to stay with the patients during that first 15 minutes. Then this is the time we are going to watch them closely for any signs of reaction. Monitor their vital signs at regular intervals to find out if they are developing any adverse reaction. If any adverse reaction occur, you stop the transfusion immediately right after that. Do not use the same normal saline which is hanging with the blood. You discard the blood, you return it to the blood bank, but you start a brand new normal saline infusion. The administration time period should not exceed more than 4 hours. Blood tubings are usually changed every 2 units are transfused, or it's the maximum recommended time is 4 hours. And sometimes the package will also say that how long you can use a certain type of filter and a tubing. So those recommendations usually come on the packages too. Post-procedure, obtain the vital signs, compare it with the baseline measurement, and document the procedure in client's medical record, including your assessment findings and tolerance to the procedure. Any procedure you do, you always document how the patient tolerated the procedure. Now, let's look at some of the common reactions which happens with transfusions. So, acute transfusion reaction include acute hemolytic reaction, febrile reaction, which is the most common one, allergic reaction, anaphylactic reaction, transfusion-associated circulatory overload or TACO, transfusion-related acute lung injury or TRALI, massive blood transfusion reaction. Now, I want you to learn about all of this in detail and pay close attention to this. You are going to have questions about TRACO, TRALI, etc. Some of the students I've taught in the past, they were like, oh, was that a typo? No, it's not a typo. It is actually a condition called TACO and TRALI. So delayed transfusion reactions can be delayed hemolytic reactions, infections, iron overload, any other infections which are blood-borne disorders. All of this can happen as a complication, especially before the 1980s when we didn't do those screening for the blood product. A lot of patients has acquired blood-borne disorders from that. So let's look at TACO, or transfusion-associated circulatory overload. So this is a common condition when there is fluid volume overload. The heart cannot handle the excessive volume. So too much blood or fluid given too quickly, especially in patients who are elderly, has a history of renal disease or heart failure, pediatric patients, they could go into transfusion-associated overload pretty quickly. The signs and symptoms usually are dyspnea, orthopnea. All of this are the heart's clinical manifestations: crackles or pulmonary edema, hypertension, tachycardia, jugular venous distension. All of these signs, if you look at that, are fluid volume overload symptoms. So what do we do? Stop transfusion, make the client sit upright, give them oxygen. Usually you will see if we are giving multiple unit of blood, they usually get diuretics, furosemide or something like that. In between the blood transfusion to take that excessive volume out, and slow further transfusions or future ones. Make sure we watch them closely for fluid volume overload. So that is fluid volume overload. That is one of the things you can see after a blood transfusion. TRALI, or transfusion-related acute lung injury, is an immune-mediated injury. So this is different from TACO. The other one is just circulatory overload. This case, there is some immune-mediated reaction happening. So what happens is that as a result of our blood cells are triggered, our immune system is triggered, which causes capillary leak in the lungs. So biggest thing, what happens here is the donor has antibodies which activate the neutrophils in our body, which causes capillary leak. So this causes pulmonary edema. Whenever there is capillary leak in the lungs, what happens is that we have the alveolar membrane. Beside that is the capillary membrane, and the air and the oxygen and the carbon dioxide exchange in that area, right? So whenever there is excessive capillary leak, there is fluid filled in the lung alveoli, which causes pulmonary edema. That condition is called pulmonary edema. So what you see in these patients is that within approximately after 6 hours of transfusion, they will have acute hypoxia because the air exchange is not happening, severe dyspnea, crackles or bilateral pulmonary infiltrate, hypotension, without any signs of fluid overload. You don't see any fluid overload symptoms, like we said, tachycardia, hypertension, jugular venous distension. None of that is there, but they have all these acute respiratory symptoms. So that's how we differentiate between the two. Treatment is almost the same: stop transfusion, supportive care, as oxygen and ventilation. Here, in this case, there is no need to give diuretics because it's not going to help. There is no fluid volume overload. So that is the difference between TACO and TRALI. One is circulatory overload. The other one is acute lung injury as a result of an immune reaction. And as a result, a capillary leak happens, pulmonary edema happens. So this is basically in the lungs. I want you to learn these two conditions really, really well. And you can expect questions from that. So the difference between the two, one is fluid overload, other one is immune injury. One you see hypertension, the other one you see hypotension, jugular venous distension present, absent. When you give diuretics, the TACO will improve. TRALI, there is no improvement because there is no fluid volume overload. So this is important, learn it. Other adverse reactions we're going to see with blood transfusion is a common one is fever. Febrile non-hemolytic transfusion reaction. So sometimes when patients do have this febrile reactions, we also see that we give pre-medication to the patients like antihistamines, antipyretics before giving blood transfusion. Second one is allergic reaction or anaphylactic reaction. That is why it's important that it could be a minor reaction like urticaria or like rashes on the skin to severe anaphylactic shock. So that's why it's important that you stay with the patient for the first 15 minutes. If that is going to happen, if anaphylaxis is happening, that will happen within right away. The blood is in the system. So stay with your patients. Dyspnea, which could be related to TRALI or TACO, hypotension, which is like immune-mediated response. Again, kind of remember we talked in TRALI that there could be hypotension. Hemolysis, acute hemolytic transfusion reaction. Is one of the other reaction you will see. Acute or delayed hemolytic reaction can happen. Both should be reported to the um, um, blood bank. So in this case, sometimes right after a transfusion, the patient will develop like severe back pain. Usually this is manifested as kidney failure, acute kidney failure. They'll have hematuria, all of those symptoms associated with it. And then cytopenias can happen. Sometimes, when even after blood transfusion, certain patients don't respond to the transfusion. Like you would see mostly in cancer patients, when we give, usually when their hemoglobin is 70, you're giving a unit of blood, it should jump up to 80 the next day. That is roughly how the blood levels will improve. But some patients, even after transfusion, you will see that their hemoglobin has not improved. That is because with multiple transfusions, we only do the ABO typing and the RH typing, right? We kind of do very minimal matching for blood. There are also something called HLA linked immune system, which we will learn later in autoimmune conditions. So because we don't do a lot of matching with some of the HLA system, they develop weird antibodies after multiple transfusions. So people who had multiple transfusions might have like some rare type of antibodies in their blood. You might have noticed this when sometimes when you get an order for blood transfusion, you ask for blood, the blood bank will say the blood is not going to be ready for a while because they have a lot of antibodies in their blood. So these antibodies develop as a result of multiple transfusions, and those antibodies will attack those cells which we transfuse. So that's why some patients, when we even after transfusion, their levels won't go up as expected because of this antibodies in the blood. Then viral infection can happen as a result of contamination of blood too. So these are some of the transfusion reactions. We talked about that. And then massive transfusion is rapid replacement of large volume of blood to treat life-threatening hemorrhages. It is typically defined as more than 4 units of PRBCs in 1 hour or more than 10 units of PRBCs within 24 hours. So that is a definition of massive transfusion protocol. Or we can also say more than 50% of the blood volume in 3 hours. All of this is massive transfusion. And remember, we talked about the coagulopathies which could develop. The purpose is to restore oxygen delivery, maintain circulation, and prevent shock. So these are the common causes of massive transfusion, like major trauma, motor vehicle collision, GI bleed or hemorrhage, esophageal varices. Remember, that's a medical emergency. Postpartum hemorrhage, placental abruption, major surgery with uncontrolled bleeding, aneurysm bleeding, severe coagulopathies. All of this could go into massive transfusion protocol. Biggest complications of massive transfusion, hypocalcemia. So citrate is used to store blood, which binds with calcium, which causes reduced calcium level in people, which lead to hypotension, arrhythmias, muscle twitching, etc. So we're watching for hypocalcemia very closely in massive transfusion. Hyperkalemia, because potassium could be, the RBCs can be disintegrated and it can cause potassium to leak outside of the RBC. That can cause hyperkalemia. Hypothermia, because the core, with massive infusions, the core body temperature always drop. So another way to deal with this is fluid warmers. If we use fluid warmers to increase the temperature, in most of the cases, you would see that when we're giving large volume of fluid or blood, they use the fluid warmers to administer that. Then dilutional coagulopathy, acid-base imbalance, etc. So these are the complications. Learn that. Priority nursing action, cardiac monitoring, because hyperkalemia, hypocalcemia can definitely cause cardiac arrhythmias. Monitor calcium, potassium, core temperature, and coagulation labs when we're giving it. Use blood warmers, as I said before. Watch them closely for taco and trally. And it's not a typo, because one of the exams I was administering in person, a gentleman asked me, Miss, did you make a mistake in the question? And I was like, you haven't read any of my PowerPoints. So immediate management, memorize this. And in this order, what is the priority management when there is transfusion reaction? First one is stop transfusion, maintain IV access, take patient's vital signs, recheck identification of patient and blood product, then you notify the physician or whoever concerned. You don't do that as a priority. What your priorities are: stopping the transfusion, making sure they have an IV access or starting an IV normal saline line, taking patients' vital signs, and making sure that you give the right blood product. And then you notify the physician and the blood bank. So again, priority actions, always airway, breathing, circulation. So airway and breathing is good. Large bore IV access, volume replacement, and correcting the coagulopathies. Some other blood products might be required in this case if they are developing coagulopathies, like fibrinogen or highly concentrated products are used. So, question: a client with cirrhosis suddenly vomits bright red blood. What is our priority action? Our priority action in case of a person vomiting, not just blood or any blood, anything, is to protect their airways. So which patient require immediate action? Platelets 9 with headache, INR 4.5, sudden dyspnea during transfusion. Always follow the ABC pattern. You won't get it wrong. So prioritization of care, sudden dyspnea patient. That's about this week's lesson.